The title, Hysteria, the Cultural Brain and Medically Unexplained Symptoms, relates to the fact that when I grew up, it was called hysteria. It was subsequently reverted to conversion disorder, or conversion subtype of dissociative disorder, as the DSM became solidified. Okay, so a case from my own work as a neurosurgeon. I've called him Robert to preserve anonymity, and that was Robert. Truck accident, started his own trucking enterprise. The injury left him confined to a wheelchair. Extensive neurological investigations couldn't discover why. He did in fact have a very large C2-3 disc prolapse which impinged on the left side of his spinal cord, but we safely removed that and nothing much changed. His pain changed to some extent, but nothing much else. At one stage, we didn't think of it as a trick. We abreacted him with midazolam, and he recovered full movement. We then intended to talk to him, well, as I was undertaking his neurosurgical care. I then passed over to the psychiatrist who'd been involved with the thought that we would be talking to him about the origin of symptoms from the brain and the fact that not all parts of his brain were open to his conscious understanding, and that therefore parts of the brain to do with all sorts of other problems in his life were creating these symptoms over which he had no control. But that he should be reassured that they didn't reflect irreparable damage to the nervous system, and therefore they could be expected to correct themselves with the appropriate support. Unfortunately, Robert had dug himself into too deep a hole to get out of, and I don't think the kind of wraparound care that some of you have been talking about was available. I was quite disappointed with the way he was followed up, and he committed suicide. So the disease that is not one, the Cartesian paradox. Descartes thought that our knowledge of ourselves and our mind was transparent and more accurate and complete than any other knowledge we might have. It was immune to doubt, certain aspects of it at least. In hysteria, conversion disorder, whatever, we realise that a person is very mistaken about him or herself in the state of his body or her body. Nevertheless, the hysterical person may actually know a great deal about what's going on around them, and a point that came up in one of the previous sessions, that actually getting the hysterical patient to talk, particularly about what is going on around them, particularly about what is happening in their family or their normal setting, will often mean that that patient makes a number of very astute observations about interpersonal dynamics and politics, carefully leaving themselves out of the picture. So there's a kind of breakdown between an astute understanding of the discursive tensions that they live with and an understanding of how they actually affect the person at the centre of the drama. And you see that reflected if you think about interviews with such patients. You'll find that they do talk a lot if you give them the chance about others, they then seem to have this curious blindness about what might be going on in themselves. The paradox that we strike, which was referred to in the hidden curriculum and in other talks that we've already had, is what I've called here the subvenience paradox. We just intuitively believe that whatever mental processes are, they supervene, they come second, they are created by brain processes. We believe that neural changes give rise to mental changes, and therefore we're puzzled when, fairly obviously, in the disorders we're talking about, mental changes seem to give rise to neural effects. So what I want to do is try and understand how that happens and what is actually going on here. Many of you have mentioned Charcot. Charcot and Freud, of course, pioneered the idea that what was talked about by spiritualists in the latter part of the 19th century as being spiritual and not natural, things like automatic writing, cases of apparent automatism and foreign voices and possession, were actually all natural phenomena arising from workings of the brain that we didn't completely understand and ought to be investigated as such. Freud understood that parts of the brain were creating complexes of cognitive and emotive representation, meaning, we might say, routines or schemata that guided our behaviour in everyday life, we might say, depending on which particular paradigm we're working with, that these parts of the brain were unconscious, that their effect on consciousness was bottom-up. And Freud tended to downplay a great deal the possibility that effects could go top-down. So his model was primarily deterministic and primarily exemplified what I called on the previous slide the supervenience or subvenience thesis, that neural changes produce mental changes, and mental changes, although they go in parallel with them, don't actually have a causal effect downward. Sartre, of course, takes exactly the opposite view, that mental life, our life of meaning, our existential life, our life among other people, number of ways of approaching this, depending on which particular philosophical route you come at it, are games of a certain kind. There are rules, you make moves, those moves produce certain outcomes, you then cope with those outcomes, they then affect how you get on or fare in the game of life. And in that game you have a role. One of the roles available is the sick role. The sick role has certain disadvantages, but it does have certain advantages, as we saw beautifully illustrated in the case of the young woman with non-epileptic seizures whose brother had a seizure disorder. Obviously, her brother was advantaged to the point where he could, with impunity, abuse her sexually, and he arguably couldn't have done that without occupying that particular place in the family. So I want also to incorporate into this discussion, and I'll work towards it, the work of Elaine Showalter, who followed up a clue she found in the writings of Charcot and wrote a book called The Female Malady, in which she discusses, among other things, conversion disorder. What about the self-knowledge that Descartes thought was transparent, relatively immune to error of certain kinds? The figure of Janus, the god of doorways, the one who looks both ways, was suggested to me by a clinical psychologist many years ago. He argued that human beings are constantly looking in two directions. What is actually physically going on with them, which they're trying to cope with, and how they give an account of themselves, the meanings they make out of that, the interpretations they put on it. And that's no easy task. We have entire university divisions of humanities, who write about and explore the world of meaning and all its intricacies. And we have separate divisions, science divisions, that explore the physical things that go on in us and in the rest of the world. And we have health sciences divisions. And we're increasingly realising that health sciences is not a subdivision of science, it's actually a bridging division that must encompass humanities and the sciences, because we're dealing with people, and people have this Janus-like quality. So people are engaged with discourse. They have to give an account of themselves, and they have to give that account not only to others, but to themselves. That's how they get on. But they're also engaged with causality, what Wittgenstein called the bedrock, the point at which our words actually have application to what we're doing and how we're being affected by things. Heidegger coined the term Dasein, being in the world, being there, just having things happen to you, but also was very aware of the fact that our situated lives, historico-culturally situated lives, enable us to make meaning or make a story out of what is happening to us. Now, my thesis is going to be that when we see a person with conversion disorder or hysteria, we see a person in whom something is lost in translation. Translating from physical, brute causality, physiology, pathophysiology, if you like, to discourse has become disrupted in a certain kind of way. One of the two figures at the bottom there, Shapiro, wrote a very good book called Personality Types, I think, some years ago. And in it he describes the characteristic styles of cognition to be found in various subtypes of mental disorder. It was written before the DSM was devised. And in it he describes the hysterical style. If you study a lot of patients with conversion disorder, what are the cognitive characteristics that they show in their thinking? Well, they're impressionistic. They rapidly pick up impressions. They often don't elaborate or inquire. And these are the students we get in medical school who will produce a story to you with a whole lot of details left out. The patient will say, it came on 2 weeks ago, and they'll accept that, but they might even mix it up when they report it back to you and say it came on 2 months ago. And with these students, you have to teach them to be precise, because their natural inclination is to get the gist of the thing and to think they've got it. But we all know that medical history taking is precision. When did it come on? What time of the day? What was happening just before that? How did it play out over the next hours or days or weeks or whatever? And if they haven't got those details precise, they are not able to make a diagnosis. and neither are you. You get the history over the phone, you have no idea what's going on with the patient. You go and see them, and you ask a few key questions, and suddenly the picture clarifies, and you can make a diagnosis. You maybe have been in the hospital 5 minutes. They've been puzzling over the case for 2 or 3 hours, and you've made a diagnosis which they couldn't make. You recommend exactly the tests that ought to be done, and you figure out what's going on. So there's this impressionistic kind of approach to thinking in the hysterical style. And there's hysterics all over the place, just that most of them don't end up with diagnosable conversion disorder. Some of them get by in everyday life. In fact, you almost cannot be a successful stage actor without being hysterical. They're emotive. They give you an emotive coloration to everything they tell you. Oh, it's a terrible headache. It was as if somebody had hit me in the head with an axe. Yeah, but how did it start? Oh, they haven't thought that. Which part of your head? Where did it go? How long did it last? Did it ease off at all? Were there any things that made it better or worse? They haven't thought about all those details. They've thought about the impact, the big picture, the all-consuming symptom that has overwhelmed them. They're dramatic. It was like I was hit in the head with an axe. Oh, that must be serious. Being hit in the head with an axe, that's not the kind of thing you can just carry on walking along the street. Of course not. They're approximate. Oh, I don't really know. You see, just after that, America's Got Talent came on the TV. Oh, I see. Now, immediately you know something about the intensity of the headache, which the person who's got the headache hasn't actually realised. It was a headache that could be significantly diminished by America's Got Talent. It's probably not a subarachnoid hemorrhage. Oh. There's an inauthenticity about it, despite the fact that the person's just told you they were distracted by America's Got Talent. Oh, it was the most terrible headache. I could hardly get rid of it. I mean, I couldn't think of anything else. It just completely, I had to come. Well, give me a break here. And it's manipulative. You are forced to do something about it. You have no choice. To turn your back on a story like that will be the height of callousness. What are you? You're a doctor. How come you're psychopathic? You have this callous unawareness of the emotional state of others. Can't you see what distress I'm in here? I mean, you're not saying this, but this is the message you're getting. There are certain similarities with pathological pain disorders, neuropathic pain, there's a number of them, and pathological pain disorders come in a number of types, and we're all aware of the fact that the basic message of pain, at least the late components of a pain event in the brain, are motivational. They're not informative. The two systems work quite differently. The epicritic or informative system goes through a specific set of pathways, has a specific thalamic termination, and has relatively limited cortical distribution. The affective system is quite otherwise. When you look at pain using the laser evoked potential method, well, when you look at pain in general, the two-stage model has been appreciated for some years, was beautifully summarised by those authors in that article, but the best book on pain is Patrick Wall's book called Pain. When you look at habituation, characteristic neurological effect, that occurs once the pain stimulus has been appropriately attended to, because after all, pain's aim is to get you to attend to a possible site of impending tissue damage. And normal pain, when appropriately attended to, immediately starts to decrease. You get habituation of the late components of the evoked potential, the N200 and P300 components. However, in chronic pain conditions, that doesn't occur. Laser evoked potential late components, particularly the N200 component, which one also finds elicited in situations where a patient is put in a conflict situation as an indeterminate or very difficult no-go task, just doesn't habituate in such patients. So they are constantly getting the message that something is happening, something alarming, something that needs to be attended to, but that isn't clearly cognisable. Your cingulate gyrus is not for cognition. It's to be the highest ganglion of the limbic system, the one that potentiates the rest of the neocortex to the importance of what's going on in the limbic system, with certain clues about what type of thing that is. A number of studies, which some of you know a lot more about than I do, have been done on conversion paralysis. Relatively easy problem to study because it's relatively constant, and you can submit a paralysed limb to certain tests, and the tests you submit it to can be simulated in a person with normal movement, and you can begin to look at the differences. Now, reaction time is the time it takes to initiate a movement when you're asked to do so, usually by some kind of cue in a timed evoked potential or averaged evoked potential task. And response duration is the length of time it takes you to execute the response. Response duration is a pretty pure move of the motor system and what has to be done to do what the task requires you to do. Reaction time is a measure really of initiation. As you're beginning to initiate the task, or as you're initiating the task or initiating your response, how easily is that happening? Interestingly, what we notice, or what has been noticed in conversion paralysis, is significant lengthenings of reaction time, but not really response duration. What's also been noticed when you look at the anterior cingulate cortex, I've already mentioned the cingulate lobe and its role in the between the limbic system and the cortex, is hyperactive monitoring from the cingulate cortex during any kind of required cued task. Now, for those of us who've dealt with the anterior cingulate cortex in other areas, you realise that it's crucial in the emotional tone of the frontal lobes. So when we combine that with findings and studies looking at event-related potentials in movement tasks, we can separate conflict, the kind of response you get in a go-no-go task, from inhibition, the kind of response you get in a stop task where you're given a signal to move and then very shortly after you're given a signal not to move, so that you have to stop or cut off the movement response. And we find that there's these two different components, and surprise, surprise, the N200 component, the conflict component is prominent in the disruption of motor initiation and conversion paralysis, and prominently occurs in the anterior cingulate area. We also, these authors that I mentioned at the bottom, in a bringing together of what is known from the literature about conversion disorder and electrical activity in the brain, came to the conclusion that conversion disorder reflects frontal and limbic activation. That's a very interesting finding in view of another paper, admittedly involving only one patient with conversion disorder, compared with 8 simulators and 24 normals, so a somewhat unbalanced sample. Nevertheless, the findings were so consistent with the other things that we know that it probably deserves the attention I'm giving it here. What they did was set up a go, no-go task involving response from either the left or right hand in a patient with conversion paralysis, as compared with 8 people simulating paralysis of the hand and 24 people who were responding normally. What they noticed was effectively that the patient with conversion disorder faced with this task had a huge amount of activation in orbitofrontal and limbic centres, as distinct from the normals who had activation where you would expect in the primary motor areas, and the simulation patients who had less of a response in the relevant primary motor area, but as a result of inhibition rather than emotive activation, limbic and inferofrontal activation. So, how do we interpret these kind of findings? What do they tell us about conversion disorder? I want to make the use of a post-psychoanalytic thinker called Jacques Lacan. Actually, his thinking, to some extent, rehearses a lot of the themes you find in Sigmund Freud's writing, but puts a bit of a post-structuralist spin on it. He discusses the idea of méconnaissance, or misknowing oneself. So you notice that we've now moved away from the Cartesian position to a writer about the human mind in a post-structural context, talking about misknowing, being subject to illusions about yourself. He relates these to skills of self-articulation. How do I articulate myself? How do I fill out my story? How do I give an account of myself to myself and others as part of the discursive world? And how does that go wrong? Well, it prominently goes wrong when something happens in the process of what he calls mirroring. Now, he regards the normal, most prominent mirror phase as the phase during which the child is developing their skills of expressing themselves, coordinating their body and so forth in the world. And he regards the self as an ortho-psychic construction. Ortho, because it's kind of orthodox, normal, but ortho also in the sense of orthopedic, to do with the limbs and joints and their coordination. And the primary role of the mirror phase is for the child to come to see themselves as a unified individual with a unified place or locatable place in the world and a certain standing among other people. Now, as you spell this out, it becomes clear that this is not all going to happen in a certain phase of childhood. It's actually going to be an extended process well into adolescence. Because the more layers you add to that, layers not only of self-coordination in a motor sense, but then self-coordination in a social sense, and ultimately self-coordination interpersonally and politically, that becomes a quite extended process. And at any stage, things can go seriously wrong with it, because the source of the mirroring is not just a physical mirror, as it is in the early stage when you're kind of learning to see and locate yourself in the world as an identifiable visuo-proprioceptive object, but is actually the regard of others. How are others looking at me? What are they saying about me? What does the tone of their voice convey about me? What does that add in to my assessment of who I am and what I'm doing? And out of this, Lacan talks about the development of an imago. Now notice the word is a condensation of image and ego. You just chop out the redundant E and G and you've got it. It's an imago. It's an image ego. It's myself as I see myself. Myself as I enact myself. And this takes me from a state of relative helplessness. I don't know how to do anything around here, which would be true of pretty well every infant. And all of us, as we grow up, women till about the age of 19, men till about 25 or later, from a state of insufficiency to a state of competent cognition. And cognition is anticipation. Anticipating what is about to happen and what role you can take in what is about to happen. If you can't anticipate, you can't cognize. If you see yourself as helpless and a victim, you're impaired in both those respects. It all plays out. Now, somebody like Metzinger, who's written about this from a neurophilosophical perspective, would argue that all this stuff is just an illusion, but of course it isn't. It's no more an illusion than being a doctor or lawyer is an illusion. Being a doctor or lawyer is an imago. It's a role in society that you've been equipped for and that you've been cognitively groomed for, so that you know how to do what you do. And if you say to somebody, oh, you think you're a doctor, but that's just an illusion, they'll say, well, tell me that next time you need brain surgery. Maybe I'll hand it over to you, give you a mirror, give you all my equipment, see how you get on. I think you realise what you are as an imago when, for instance, as a neurosurgeon, and this happened to me very vividly once when I walked into the entrance hall at the National Hospital for Nervous Diseases at Queen Square, and I arrived with my suitcase for a week's locum, and I thought, why the hell are they going to pay me this money? What am I bringing? I have no equipment. I have nothing. I've just got me and what's been constructed in this brain of mine. And yet when I interface that with what exists here in the National Hospital for Nervous and Mental Diseases, things are going to happen and people are going to be healed. Now, to call that an illusion or a fiction, just because it applies to something a little more ephemeral than being a neurosurgeon, it seems to me is the height of ignorance, but I would never say that of a neurophilosopher. In fact, we live in a world that we do construct. Some of the things we construct physically and some in other ways. Physically, we construct bridges and buildings, and in other ways, we construct things that have a kind of physical reality, but to see them as a set of physical things would be to misconstrue them. We've constructed this virtual system called PowerPoint that means that I can refer to something there and you can see it, so it's got an objective reality or an intersubjective reality. What's the difference? And yet that's not just a physical thing. That's a kind of virtual thing. When we start thinking about being among others, about the self we construct to live and enact, we then begin to see how it is we are all trying to function. And I like the fact that this is a caricature of Friedrich Nietzsche, because the medium is the message. This caricature, one might argue, is truer to Friedrich Nietzsche than a photograph. It's captured the essence of him. You and I produce a caricature. You ladies won't have seen it, but most of us men will have walked into a certain very small room in certain public places and seen a sign in front of us saying, "Relax, even the president looks ridiculous in your position." Now, that doesn't get into our caricature. Notice in Hollywood movies, you don't often see people going to the toilet. Notice in James Joyce's Ulysses, one of the most shocking things about the book is that he, in some detail, recalls himself going, or records an account of himself going to the toilet. We all produce a caricature. We dress a certain way. We have facial expressions that are a certain way. Sometimes when you see a person outside of the setting in which you're used to seeing the facial expression they normally present to you, you don't recognise them. Why? Because actually you're seeing a caricature most of the time. A caricature that answers certain questions. It answers the question, who am I? When I look at myself and how I conduct myself, I'm going to be able to also answer the question, where am I? When I think about the kinds of things I'm saying, I'm going to be able to read off that who wants to know, who it is I'm addressing, what they want to hear. And I might even be able to answer the question, what do they want to know that for? Because all these questions go into my self-definition at any particular moment. I'm going to shift along a bit here. So I have a set of permissible deficiencies in my normal situation. Any of us is allowed to have emotional or moral conflict. If I were to speak to you about a particularly tragic case of a child who died in my care, it will be okay for me to tear up. If I'm presenting myself as a purely academic lecturer, it's not okay for me to tear up. If I didn't feel any emotional or moral conflict about speaking about something very close to my heart, rather than merely a topic of academic importance, you would wonder if I didn't actually show any sign of emotion at all. Is he on beta blockers? Is there something wrong with his amygdala? You might think. We're all allowed kind of deficient skills of articulation and resolution to some extent. We all meet situations where there is an impossible demand. And in those situations, we face varieties of debilitation. Sometime today, I was going to be giving expert evidence via Skype in a trial of child abuse in New Zealand. As a matter of fact, the defence attorney yesterday evening had some kind of heart episode and the trial has all been deferred. So all the deficiencies that I was experiencing yesterday evening about being able to get on Skype and getting into effective contact with New Zealand are no longer an issue. So we all have varieties of debilitation. Take any high-functioning doctor away from the support of their personal assistant or secretary, and they will show all the classic signs of dementia. We won't give them a diagnosis of Alzheimer's. We'll give them a diagnosis of secretariitis or something. What happens is there's a detachment of cathexis, what I want to do, what I need to do, what I need to express and how I feel, from cognitive articulation and the techniques available to me as a self. The term techniques of the self is related to the work of Michel Foucault. Now, techniques of the self we all use all the time. So let's look at hysteria through the lens that we've now got to examine it with. Breuer and Freud enunciated the idea that it was a naturalistic disorder of the psyche. I prefer the term psyche. The mind sounds far too cognitive. The Greek term psyche, or its transliteration, the soul, is a much more holistic way to refer to our mental function. Elaine Showalter argues that what we see in hysteria and in conversion disorder is the body telling us what the person can't tell us, or hasn't got the discursive space or techniques open to them to talk about. A couple of quotes. A feature that doesn't emerge in the standard history of psychiatry about hysteria, or indeed about automatism and those things, but things that Ian Hacking, among others, have written about. Freud and Breuer saw the repetitive domestic routines, including needlework, knitting, playing scales and sickbed nursing, to which bright women were frequently confined, as the causes of hysterical illness. They very quickly suppressed that idea, became surpassed by Freud's concentration on the unconscious. But in their notes and in their initial observations, there it is. Freud failed Dora because he was too quick to impose his own language on her mute communications. His insistence on the sexual origins of hysteria blinded him to the social factors contributing to it. Now, we don't want to paint too simplistic a picture. We also know that Freud was probably blinded to a lot of the sexual abuse that was going on in some of his patients. But nevertheless, when we take a more inclusive view of these things and the observations that were made, these people were very astute clinicians. They had nothing else to go on. None of the imaging techniques we've got. They had to be. And if you look in detail at their observations and don't always look at them through the restrictive lens of the theories we've associated with them, you often see insights there into clinical conditions that you won't get anywhere else. So, how can we reconstruct the hysteric? Well, probably the best guide here is faulty towers. You get yourself into a situation, there's no way out. You just get deeper and deeper and deeper. Now, if you're John Cleese, you can turn it into high comedy. It gets funnier and funnier and painfully funny. A kind of painful funniness that the British do very well. The British version of The Office. Faulty Towers. You name it. Painfully funny. What we see is a person lacking certain life skills to live through the ordinary challenges and losing it when he can't do that. He beats up his car because it won't start. He beats up his Spanish waiter because he doesn't do, because he takes his words literally rather than his British colloquialisms. So one way of thinking of certain cases of hysteria is the faulty towers dilemma. When you've dug yourself in deep enough, it's almost impossible to get out. And some kind of wraparound understanding of the way you've got there is going to be needed to unravel a way of possibly getting out. What's the truth? The truth is something is going down between the brain and the world. And any of us, in our own case, doesn't always know the ins and outs of that in any great detail. What we call, or what Freud called the unconscious, is the areas where that gap makes itself manifest, where our engagement with meaning becomes unsustainable in the light of what's actually going on in our lives. So what are the ethical approaches perhaps we should be taking to hysteria? Well, the essence of all ethics, again, this is due to Michel Foucault in his last unfinished work on subjectivity and ethics, is to connect the subject in a certain way with the truth. The aim ultimately has to be that the person with conversion disorder gets out of the false consciousness they've got themselves into. Foucault has some very insightful comments, not usually brought to bear on this subject. Dissent attaches itself to the body. It inscribes itself in the nervous system and temperament, in the digestive apparatus. It appears in faulty respiration, in improper diets, in the debilitated and prostrate bodies of those whose ancestors committed errors. We could add in whose ancestor selves are deemed to have committed errors, and we would have a more full comment on the situation. Dissent, what does he mean by dissent? He means descent from the level of discourse and personal politics to the level of physical manifestation. Exactly the opposite of the subvenience hypothesis, which creates in us this terrible misunderstanding of hysteria as faking it. The problem is at once to distinguish among events, to differentiate the networks and levels to which they belong, and to reconstitute the lines along which they are connected and engender one another. What is engendering what I am seeing? What is it connected to? Why is it taking this form? Reconstitute those connections, those lines of engenderment, and you begin to understand what's going on. Is there So we ask ourselves the question, is there a livable way to health in this aporia? The Greek aporia is a point at which you can go no further. You can go no further either because there's no way out that you can see, or there's so many ways out you don't know which one to take. They're all conflicting, and there's too many of them. So that's the theoretical framework with which I think as clinicians and as thinkers about philosophy, psychiatry, the human mind, we can approach this puzzling subject. I don't think there needs to be any knowledge gap between theoretical analysis and clinical application. Indeed, when I'm talking to a patient whom I suspect has got medically unexplained elements to their symptoms, I often make use of exactly this framework. I say, look, the brain throws up all kinds of things, and you live with the results of that. And what's going on deep in your brain is something that you actually don't fully know. You can get to know a lot more about it, but that's not easy. It takes a lot of work and a lot of honesty and a lot of courage, and frankly some of the insights are too hard for people at certain stages of their life. So let's just see how we can work with what's happening with you at the moment and see what kinds of paths that seems to open up. And let's see if some of those things that are going on in your brain that we don't fully understand, we can start to get a bit more insight into, and perhaps things might change a bit. Over to you. Paul.
So, Grant, I appreciate your talk. Given the earlier panel, one of our panelists had a slide that showed a road sign that said, we don't blame you for your cancer, and the idea being you shouldn't blame someone for their mental health condition. Another panelist talked about patient responsibility. So how do you frame what you said? You see where I'm going here. What you said, where do you frame who I am and my responsibility to be me, but not blaming people for a pathology or a condition I don't want to be in, or whatever it is that is. How do you talk to them equal parts what your responsibility is for better and not dropping blame?
Yeah, there's a very close parallel here, and one that you've already spotted, between cancer diagnosis and hysteria. We all know that at a certain point we have to tell our cancer patient that they've got cancer, and we have to tell them what that means. We all know that it's kind of counterproductive to dump that on them if they're not yet equipped or brought to the point where they can hear it and in some kind of healthy way. And one of our mistakes in the past has been to erect a false dichotomy between brutal truth and deception. We all know nowadays that our job is to care for the person to the point where they can receive that diagnosis, and that if we do that effectively, in some cases require a bit more urgency and application than others, then when we do tell them what their diagnosis is as part of the healthcare episode, they will actually be much more ready and able to hear it and to move forward than be completely destroyed by the diagnosis. Now, I think we've yet to learn that lesson with some of these other problems for which we naturally tend to have a lot less compassion because we feel we're being duped or deceived or manipulated, which indeed we are. But I think at a certain point we do have to acquaint a person with the fact that it's a difficult business facing up to your responsibilities and the realities of your life. And we have to realise that bringing the person to the point where they can receive that requires a great deal of care and support that maybe in certain areas of their life is very profoundly lacking. And so we also need to diagnose those areas of lack and find people, not necessarily people with designated roles, who can fill those lacks. And I think another point that came up in the caregiving talk was that often a lack is being created, or a defect is being created in a patient or intensified in a patient by one of the people around them who actually needs the patient to be the way that they are. And if the patient wasn't the way that they were, that person would have something essential to their own to what they consider to be their own well-being, they're mistaken about it, go out of their life. And we see this, of course, dramatically illustrated in Munchausen's by proxy. Yeah.
This may not be true, but implicit, not articulated in your talk, I'm wondering if you make a distinction between pre-reflective self-consciousness and reflective self-consciousness, and also body schema and body image. And obviously, you know what I'm talking about from Maurice Merleau-Ponty, and then more recently, people like Sean Gallagher, Dan Sahabi. I'm just wondering how this fits into your theoretical frame.
Yeah, the connections seem to be complex, but the more you reflect on them, the more obvious they become. There's a kind of very pre-reflective, natural indwelling of the body, or ipseity, if we want to use that term, that most of us manage pretty well. But some of us, to various degrees, suffer a disruption in that. And one of the unrecognised disruptions, I think, is adoption. Yeah. So an adopted child has grown in the womb with a certain kind of reciprocity going on, and suddenly the person close to them, in whom that relationship might be expected to be continued, has got a totally different set of body characteristics from the body they grew up in. And that kind of throws out their primitive, pre-reflective, natural sense of rhythm on which all our other pre-reflective rhythms of life are built. So there is this whole business of pre-reflective rhythms of life and responses to the world and the things we find natural and don't even think about. Then there's our level of being aware of ourselves doing those things, and that's reflective consciousness. And I think there's an interesting study to be done on the earliest awareness of reflective consciousness in adoptive children as distinct from natural children. And I think you would find that in adoptive children it is enhanced. Reflective consciousness is both confused but also much earlier in onset, because there's a puzzle about their own embodiment. The other point you mentioned was... Okay. Body schema and body image.
So body image and hysteria, for example,
Yeah.
versus the body schema.
Body schema is the basis of your enactment in the world. Body image is the way you think about yourself, and there's a possible gap between those two. And body schema, we've done too much. I mean, Merleau-Ponty was terrific, and he was aware of the wider implications. And when you read some of his work, you realise that actually, particularly as it's reflected in Emmanuel Levinas, you realise that he was well aware that what he talked of as a very biological embodiment. He actually understood as a very situated embodiment with the benefit of Heidegger's work and so forth. So body schema is often, and body image are often both simplified in the neurophilosophical literature beyond the point where Merleau-Ponty would have them.